Hello, everyone. We are going to get started in just a moment here. This is the ONC Cures Rule 2015 edition updates and conditions and maintenance of certification. This is a webinar that will have a shorter presentation followed by addressing questions. For everyone's awareness, we will not be using the chat function for questions during this webinar. Please submit your questions using the Q&A feature. You can see it looks like two little bubbles at the bottom of your Zoom. If you submit your questions using that feature, we can address them as we go during the presentation. The second half is where we will be addressing questions. We're going to get started in just a minute, just watching the attendees as everyone gets in and gets settled. Again, reminder, we will not be using the chat function for questions. We will be using the Q&A feature at the bottom of the Zoom. So we'll go ahead and get started. If we can go to the next slide. Just a quick note and reminder, the materials contained in this presentation are based on the provisions of our regulation, and while every effort has been made to ensure the accuracy of these restatements of those provisions, this presentation is not a legal document. The official program requirements are contained in the relevant laws and regulations. As you may know, our regulation is now on display in the Federal Register with a publication date of May 1st expected. So that is the source of truth for all program requirements, and we will be discussing those throughout this, but again, please keep in mind that is where you should look for the actual regulation. Also, this communication is produced and disseminated at U.S. taxpayer expense. If we can go to the next slide. Quick note here, the other announcement that was made yesterday, in addition to the publication, or I'm sorry, the display of our rule on the Federal Register, is that in light of the COVID-19 crisis, ONC will exercise its discretion in enforcing all new requirements under 45 CFR Part 170 that have compliance dates and timeframes until 3 months after each initial compliance date or timeline identified in the ONC Cures Act final rule. What you see there, you might have seen before if you've been following along with us for the past month and a half. That is the certification and information blocking timeline of all of the various compliance dates that we had available on our website. You'll note that this version of it is still missing the publication date, which is now May 1st, and that those timelines all represent those that were finalized in the rule. If you can go to the next slide. We will be updating these resources to provide more information, but you can also find a table that looks like this, and there's two more pieces of it on the next two slides. If we can go to the next one. That show the compliance date and time frame, and then the 3-month enforcement discretion time frame applicable for the various conditions of certification. Next slide. And for the ONC ACB directional pieces of the regulation. That is available on our website, which we will show a link to you at the end. I'm not going to spend time going through each one because we have a lot to cover today and we want to make sure that we can get to your questions. But again, that announcement was made yesterday that in light of the COVID-19 crisis, we are doing a 3-month period of enforcement discretion for the compliance timeline stated in the regulation. So we can go to the next slide and get started on the meat of the discussion. Today, what we're focusing on are the updates to the 2015 edition certification criteria and the conditions and maintenance of certification requirements. So these are specifically the provisions within the rule that relate to certified health IT developers, that is health IT developers who are participating in ONC's voluntary certification program. So wanting to be very clear about that, remember, CMS has also published a rule that references some of the standards that we're going to talk about today. The CMS rule and the CMS policies are under CMS programs and relate to their authorities. And the things that we're talking about here today relate to certified health IT and the authorities of ONC for the ONC certification program. Next slide, please. So we're going to try and get through this part of the presentation a little bit faster than we have in previous, but if you want more detail, we do have an overview presentation that we did several weeks ago that is available as a recording on our website. This webinar will also be recorded and made available on our website, healthit.gov/curesrule, so that you can get access to the slides as well as the recording of that after the website has concluded. So really quickly, some of the updates to the certification criteria, as you all may know at this point in time, we did not adopt a new edition of certification criteria. We focused on updating the existing criteria, either with standards updates to the US CDI to expand the set of baseline data that are required to move from place to place, or to do other types of updates that essentially update the standard associated in the case of the standardized API for patient and population services, or for electronic health information export to align that data to the information blocking definition of the data that is required to move from place to place under information blocking. I just want to highlight a couple things in here that are important for reference. There is a bullet that says interoperability criteria. This includes things like the transitions of care, the view, download, transmit, as well as the application programming interface. Each of those have been updated with the US CDI. This is an important point to note, and we will address if we get more questions on it, but the application programming interface is not the only certification criteria that also references the US CDI. The other thing I want to point out is there are several things that have been removed or time limited. We've been getting several questions about those time limited criteria. Again, just to reiterate, those criteria are not removed from the program until after the Medicare, or I'm sorry, the Medicaid EHR incentive programs, which uses some of those criteria, sunset. So they are still applicable and available in certification up to that point in time, at which point they will be sunset along with that program. Next slide, please. The US CDI, I'm just going to talk quickly about a couple things in the US CDI for reference. The United States Core Data for Interoperability, again, this is the standard that ONC has established in the final rule that will replace the Common Clinical Data Set, which was the prior sort of list of things that were required to move from point to point. The US CDI itself is a standard that includes data classes and data elements that specifically define the scope of clinical data that needs to be moved through certification criteria, but it's also the standard that is referenced, as mentioned previously, by the CMS programs as the clinical data that may need to move for some of their requirements. And this is also the set of data that is referenced in the Trusted Exchange Framework and Common Agreement, which is implementing another part of the Cures Act to deal with trusted exchange across networks. There are 4 new data classes within the US CDI that expand from the CCDS. They are provenance, clinical notes, pediatric vital signs, and address, email, and phone number. Keeping in mind, address, email, and phone number are essential additions to the demographic set that is a very key piece of ensuring accurate and efficacious patient matching. Next slide, please. So we have also revised the electronic prescribing clinical quality measures criteria. In each of these cases, those criteria are aligned to what CMS programs require for healthcare providers that may be using these technologies. In the case of electronic prescribing, the standard has been aligned with Part D standard. In the case of clinical quality measures, the requirement for the reporting criterion has been aligned to the CMS QRDA implementation guides. This is to remove some redundancy for the clinical quality measures around doing both the HL7 standard and then subsequently being required to do that for CMS reporting without having that be the certified portion. Next slide, please. The security tags, really quick update here. Wanted to make it clear that the piece that we are talking about is one part of the full chain of data segmentation for privacy. So we've made the revisions to the name of these criteria. We've also expanded the criteria to include the full scope of the HL7 standard so that it can be tagged at the document section and entry level. Again, this is the portion of a process that is a larger process to meet segmentation and privacy needs that would allow for security tagging. Next slide, please. The new electronic health information export criterion. This is one of our new criteria. This is very, very important to note. The EHI definition for this criterion is aligned to the EHI definition for information blocking. So that is a focused definition of EHI to electronic protected health information to the extent that it would be included in a designated record set. So it is aligned to information blocking, which is also aligned to HIPAA. want to make clear that this is a criterion that includes 2 use cases. One is for a single patient EHI export, and the other is for a patient population. This is to allow not only a single patient export, but also to allow for use cases such as moving across systems, switching to a new product, or moving from one setting to another setting. The export files themselves must be electronic and in a computable format, and they need to be, the definitions for that, or the format itself, needs to be publicly accessible via hyperlink. Next slide, please. The new application programming interface criteria, when we talk about this one, I think the big thing that we have said over and over, which is probably not news anymore after it's been several weeks since the announcement was made, but we did adopt FHIR Release 4 for this criterion, and we are looking at both the single patient data access and the multiple patient data use cases for this certification criterion. Next slide, please. Yep, thank you. So I want to really quickly touch on this one, and then we'll be passing off and going through a quick overview of the conditions of certification. The privacy and security transparency attestations, this is very important to understand that these are very much about transparency. These are yes/no attestations. We have finalized the ability for a developer to include an explanation if they attest no to either of these. So these are, does the product have encryption authentication credentials is one, and then there is a separate one for multi-factor authentication. And again, we have finalized that there would be an explanatory capability for health IT developers to note what the reasoning would be behind if they have had a no attestation to these. Next slide. So I'm going to pass it off to Rob Anthony, who is Director of the ONC Certification and Testing Program, to walk us through the conditions and maintenance of certification requirements. Rob?
Thank you, Beth. I am going to give an overview of conditions and maintenance of certification requirements. This is an entirely new area for the certification program, and I have been asked to do so in about 15 minutes. So you are going to get a very high-level overview of conditions and maintenance of certification. This will be recorded and posted later so that people can go back and review, but I would also encourage, we did a webinar that was a bit more of a deeper dive into conditions and maintenance of certification requirements, and we'll give a little bit more background and information that people can take a look at on our website, and I would encourage you to go ahead and take a look at that as well. Next slide. So Congress, through the 21st Century Cures Act, established these conditions of certification and maintenance of certification requirements that we had to fold into the ONC Health IT certification program. And these top 6 of these conditions and maintenance of certification requirements are what I'm going to cover today. Another requirement that was in the law was the EHR reporting criteria submission, and as we indicated in the regulation, we are deferring that for future rulemaking. So we're going to cover 6 of these 7 required certification and maintenance requirements. I think it is important to sort of note for folks here that unlike some of the other conditions and maintenance, or some of the other certification requirements that are applicable to individual health IT modules, many of the conditions and maintenance of certification requirements are more broadly applicable to health IT developers as a whole, or to the business practices relative to their certified health IT products. So they are not necessarily about an individual module, but they are applicable to health IT developers. And I want to make that note because often we're getting asked about what a provider has to do on this. And the answer is that these are applicable to certification for developers. Next slide. So information blocking is the first condition of certification. Just very broadly, it does establish that a health IT developer cannot take actions that constitute information blocking. There are a number of exceptions that you can look at in the regulation for things that may make sense. For example, an exception where prohibiting or blocking information for preventing harm would make sense. There are some exceptions for things like infeasibility about uncontrollable events. Won't go delve deeply into that, but this broadly defines that actions cannot be taken by a health IT developer information block. There's no on maintenance of certification requirements, and as we go through these, you're going to see that there is an initial condition of certification for most of these, and then an ongoing maintenance of certification requirement for many of them. In this case, the ongoing maintenance of certification requirement is that the health IT developer continues not to take actions that would constitute information blocking. Next slide. The assurances condition of certification is really nothing new. I think for most people who are participating in the ONC Health IT certification program, we have always expected developers to conform to the requirements of the program. This particular condition does make that explicit, that you have to provide the full capability of a certified product to your customers, including providing documentation support and other assistance that is reasonably necessary. So I think that is nothing new for people. I think what is new here is some of what has been covered in Beth's previous slides for new criteria. You will find the reference to implementing the B10 electronic health information export criterion here, which does require that within 36 months after the publication date, the developer that has a product that stores electronic health information has to make that bulk export criterion available to its customers. There are also some ongoing maintenance of certification requirements regarding records and information retention. But overall, I think this is a condition that people who are already adhering to areas will be familiar with in adhering overall to certification requirements for the program. Next slide. There is an extensive section on communications and really delves into what a developer may not prohibit or restrict communication-wise regarding usability of the product, interoperability, users' experiences, business practices. The purpose here is just to make sure that there can be an exchange of health information ideas and to make sure that developers are not improperly restricting any of those protected communications. This is with respect to health IT that is certified under the ONC Health IT certification program. It only covers that. And there are some areas that are set up for permitting some prohibitions and restrictions. And the regulation does go into some detail about ways that intellectual property can be protected. Screenshots may be limited so that they are not altered in presentation, but it does protect overall communications of customers. There's a maintenance of certification requirement here that a health IT developer needs to notify all of its customers that any contractual agreement they may have that would violate this communication condition of certification will not be enforced, and that is required to be notified until that is removed from the contract overall. Again, this is an area that has a fair amount of detail to it, and I would encourage people to take a look at where a developer is not permitted to prohibit or restrict those communications, and then to see where there are some prohibited and prohibitions and restrictions that are available. Next slide. Another major area that was required was around APIs, the application programming interfaces. We establish the API here, the use of that certified API, and the way in which it must be deployed. You'll see some definitions within the section around what constitutes certified API technology, who gets defined as an API developer, API users and information sources. But overall, this really focuses on a developer publishing all of the terms and conditions for its certified API technology, noting any of the fees or restrictions, limitations, everything that goes into the actual use of API in order to encourage an open and fair marketplace with APIs. Next slide. So you'll see these are the primary areas that are covered with the API conditions of certification. There's, again, a fair amount of information in here, but we clarify a transparency requirement. So the information that must be published from certified API developers about business and technical documentation to make it necessary to interact with that API technology. We put some requirements around criteria for fees that are allowable, boundaries for fees that are permitted to be charged and to whom those fees can be charged, and then generally set conditions and business requirements that promote an open and competitive marketplace for APIs. Again, a lot of requirements in this area and a lot of specifications. So I will not go deeply into this, but I encourage people to do a deeper dive into this because it regulates some of the areas of what can and can't be done in deployment of APIs with certified health IT. Next slide. And similarly, in a couple maintenance of certification, we address some of the ongoing requirements here around deployment. We sketch out some of the processes that are allowable for verifying the authenticity of API users in order to ensure that that process is the same for everybody and everybody can take part in it and that it is done in a timely way. We specify requirements around API registration that enables everyone to be able to register to use the product and the time frame, a timely way in which that must be done. And then, of course, we put some requirements around the publication of the service-based URL that people can use for accessing electronic health information. Next slide. So one of the major additions, I think, to the universe of certified products is this concept of real-world testing that has been implemented. Very broadly, the notion of real-world testing was to make sure that when certified health IT is deployed in a production environment, that it continues to demonstrate conformance to the full scope of all of the applicable certification criteria. And that would be true within the individual workflows and systems and architectures for which it is marketed and designed and operated. And so we have set this up with a notion of submitting plans and then submitting test results. And that is what you will see in the maintenance of certification requirement. There is a requirement to submit a real-world testing plan to the ACB by a date that enables that plan to be publicly published and available, which we will do on the Certified Health IT product list, the chapel, by December 15th of each calendar year. You would then take the following year to do real-world testing, theoretically, and then you would submit after that year real-world testing results based on the plan that you had submitted earlier. Your real-world testing results would happen no later than March 15th. The following calendar year. So to put some actual dates around this, because I think it gets a little bit confusing, for 2021 real-world testing, there will be a requirement to submit a real-world testing plan, ideally ahead of 2021 by December 15th. Obviously, we are providing the 3-month enforcement window, so it can be a little bit later. But theoretically, by December 15th of this year, you would submit a testing plan for 2021. You would take 2021 to do some of that real-world testing. You would compile that, and you would return and submit a real-world testing results based on the plan that you had done on March 15th of 2022 for the 2021 respective results. Hopefully that helps clear things up for folks. I know that the December 15th and March 15th was a little bit misleading for some folks, and they thought they were immediately turning around and submitting something 4 months later, but it's actually a year and 4 months. I can't go into a great deal of depth right now with the time that we have, but we do lay out some requirements some of the things that have to be included in the real-world testing plan, testing methodologies, the care settings that you are testing for, which version of the standard you are using, specific criteria to which this is applicable, so e-prescribing, for example, all of which has to be included within that real-world testing plan. Again, can't go deeply into it here, but that is sketched out in the rule. And in our previous presentations, I would encourage people to go and take a look at that. As with anything, it is the responsibility as you are going through and doing real-world testing to notify your ACB of any nonconformity that you have with program requirements, and then working with the ACB to bring the product into conformance. Next slide. And then finally, after you have gone through all of these, you get to attestations, and attestations is simply going back and attesting to complying with those conditions and maintenance of certification requirements that we have already talked about. Obviously not the EHR reporting criteria submissions, which we have deferred that, but all of the previous things. You will go through and you will submit those every 6 months, beginning in April of next year. It is an attestation window that will open for 30 days. So the first attestation period will open on April 1st of 2021. And it would have gone through the end of April. We are going to provide an additional open window for people for 3 months following that first attestation period. But for example, as we move to the next attestation period, that will be open October 1st through October 31st. And that will cover the 6-month period prior. The first attestation period covers a much longer attestation period. It's going to cover from the effective date of the regulation through the opening of that first attestation period. So essentially from, I believe it is June 30th through March 31st of 2021. Thereafter, it'll be every 6 months. We will be firming up some of that attestation language, and you will see some of that begin to appear in some of the certification resources as we move forward. But again, the attestation condition is attesting to having met and continuing to meet the previous conditions and maintenance of certification requirements. Next slide. So we have a fair amount of information, I think, about all of these on our website. You can go directly to an area on our website for the Cures Act final rule. There is a resource section. There are some fact sheets that delve a little bit deeper into some of these different concepts. There's also a section here you can see for webinars. So if you want to access the previous deeper dive webinars or go back and take a look at this webinar, that is where you will find the links for those. And then I will turn this back over, I believe, to Beth.
Yes, thank you. So thank you to those who have already been entering questions into the Q&A feature. We will be aiming to get through as many of them as possible, keeping in mind there are several hundred participants on this webinar, so we will do our best to get to as many as possible. And we did try, as we were presenting, to incorporate some of the answers to questions that we have already been receiving via email. So I'm going to start off going back. There have been several follow-up questions on the announcement made yesterday. We do not want to spend too much time on it because the easiest thing to do is to go to what you see there on our website, that enforcement discretion tab. There is a fact sheet that lays it out. That's that table that I showed in the deck. And now obviously this deck will also be available. But Mike, can you just restate that for us? The announcement that ONC made yesterday in relation to the COVID-19 crisis, what is being delayed?
Sure. So I think, and you can hear me, right? Correct? I'm going to make sure I'm off mute.
Yes, thank you.
It happens sometimes. Thanks. So we didn't delay anything. I think that's needs to be key in terms of getting across. So the rule will publish on May 1st, and that will start, so to speak, the clock on all the various dates, including when the effective date of the rule would be, which would be 60 days after that date. And then the compliance timeframes begin also on May 1st. So for example, let's just use, I guess, the EHI export rollout, if anyone's familiar with that. It's functionality that developers would have to roll out within 36 months. that still provision is still there. That hasn't been changed. But what we've said is that we'll exercise enforcement discretion. So, for example, if that's rolled out in month 37 or 38 or even month 39, we've said we would take no enforcement action. No, there wouldn't be considered non-compliance with the condition of certification if that were to happen. Similarly, as you heard my colleague Rob talk about the attestation piece, same goes with other specific dates. So, you know, again, you know, the real world testing one, if you don't get it in by the December date, you've got 3 more months in which to get that in, and we would not take any type of enforcement action. So those are a couple examples of how that would actually work, and we lay that out in our fact sheet as Beth noted. And I want to be clear again, this is the ONC Health IT certification program. It doesn't impact information blocking. There's nothing in the rule that talks about this either. I did get a similar question like that, Beth. It's in our statements that we issued about enforcement discretion. And then as far as information blocking goes, our colleagues at the Office of the Inspector General have noted that they would take no enforcement action until they issued a final rule for their civil monetary penalties proposed rule that they also just put on display at the Office of the Federal Register yesterday. So they'll have to go through that whole process to get a final rule and then an effective date before they would be taking any type of enforcement action. And they've also told commenters feel free to provide comments related to COVID-19 in terms of how they should approach their enforcement posture as well. Thanks, Beth.
Great, thank you, Mike. I'm going to do the next question myself. There's a couple things that have come in that are sort of tangentially related, one specific to CQMs, but a couple more broadly. So I mentioned that there were several updates that had been done to various criteria to update the standards, including things to update from the CCDS to the USCDI. And those are all covered under the real world testing maintenance of certification requirements. So in essence, that 24-month, now 3 additional months on that is noted there is actually a scope for the end of the requirement. So those can be begun at any point in time, and those updates can be made. And the way that we have defined this in the rule is that the developer would inform the ACB that they have made the update, and then they need to make that update available to customers. And then those capabilities would be a part of their real world testing plan. So for those criteria that specifically reference that, it is not a, we're getting several questions that say the word recertify. It is not a quote recertification. It is a notification to the ACB, making it available to customers and including as part of your real world testing plan. So want to go ahead and get that one covered. And then I have one for you, Mike. Are you ready? We actually had the other side of this.
Sure.
We had the other side of this question on the IB one, so I'm calling you out on it. There is some confusion related to the USCDI timeline, the 24 months plus 3 months for enforcement discretion versus the USCDI in the information blocking. Can you just really quickly, I know you talked about it from the IB point of view at the last webinar, this time, can you talk about it and tell us which are the criteria that updated, and even if it's just broadly, is it just the API or others that need to be updated for the USCDI, and how does that relate to the information blocking requirement?
Sure. Yeah, I don't know if I'll do it quickly, but I'll try. Okay. So the real world testing condition of certification is where the responsibility lies for developers in terms of updating to the USCDI. So the criteria there, for example, those include view, download, and transmit, the transition of care one, and then I think the API one for all data requests is another one off the top of my head. And so they have 24 months essentially in which developers, that is, to update their products. And as you heard Beth say, they're not coming back in to get recertified. They just have to update from their current product that is certified to the Common Clinical Data Set. And so there's some few new elements, obviously, data elements in the US CDI. So they're going to update their product to that within that 2 months time frame, and then roll that out to their customers, all within that 2-year period. And as we've been talking about from an enforcement discretion, there is a 3-month window after those 24 months in which they can continue to do that, roll that out if they couldn't get it done in the 24 months, and we wouldn't take any type of enforcement action for noncompliance. Similarly, I want to mention each of this time frame is embedded in those criteria, and so from a certification perspective and the certification body perspective, you could come in as a developer and continue to get your product, let's say, certified to the Common Clinical Data Set for the transition to care criterion up to 24 months, and then after that, you have to only be able to, the certification bodies can only certify you to US CDI for that criterion. Again, there'd be this 3-month enforcement discretion period. So an ACB could, if it wanted to, continue to certify to CCDS for 3 more months, a Common Clinical Data Set, before being required to only certify to the US CDI. So that's it on the certification side. And generally speaking, what you should think from a bigger framework perspective is what we're trying to do in the certification program is get tech updated to these new standards and functionality to improve interoperability. And then that's going to, those actors that are covered under information blocking are then going to have some more technological means to support providing EHI. So, having said that, let's do a quick flip over to information blocking. And information blocking, one, when it references the US CDI, it's talking about the data in the US CDI, not the data associated with the standards. To be clear, if you have it available in that way, then as an actor covered and someone's asking for the EHI, and there's no, putting aside all the exceptions that don't apply, you can provide it that way. But a really good example is always problems for me, problem lists and problems to point out, because we require coding in SNOMED CT through the US CDI standard, but it can also be coded with ICD-10. And so you could provide it in that way instead of using SNOMED, for example, if that's the only way you had that particular problem data. But that's what we're talking about, the data in the US CDI, and that is for the first essentially 18 months after compliance is required. You're going to be providing, the EHI is limited to that data that's referenced in the US CDI. So hopefully that helps clear up that distinction between the program and information blocking.
Yes, thank you. So I'm just going to state it back in the shortest way I can. The US CDI update for products, the 24-month period plus the 3-month period, and in that 24-month period in between, there could be certification to the CCDS or the US CDI. And then the 6-month is referencing the US CDI in the scope of these are the types of things, not the specific standard or the specific functionality that is required in order to provide those things. So it's just giving essentially a list of the data elements for information blocking.
Yeah, and it's, I didn't, it's still 20, it's so, just so folks understand all the various dates being thrown around, it's still a 24-month period in which we're holding under information blocking from a policy regulatory perspective to just the US CDI. But why I said 18 months is the first 6 months, actors don't have to comply from the publication date. So they have 6-month grace period before compliance is required, or I wouldn't say complied, it's that they are subject to the information blocking provisions. There's a 6-month grace period.
Right, and at the end of that 6 months, the US CDI is not suddenly you must use those standards. It is that those are the types of things that would have to move in whatever manner the patient is asking for, and then you go through the content and manner exception to get to what that really looks like.
Right. Yeah. So, I mean, we don't, this isn't an info blocking webinar, and we've
Right, I
given
know.
those, and hopefully you can go back to that. But yeah, they can request it, but there's a lot of exceptions in how that plays out, whether you're even technically able to provide that data through whatever, even certified means that you may have. You may not still be able to technically provide that data, even
Got
if you
it.
had a certified way. So,
Okay,
anyhow.
thank you, Mike. Avin, I'm going to pass one to you that is also still USCDI. I actually have two for you that are USCDI, if you don't mind. But we'll start with this one, and then I actually have one on that I'll take, and then I'll pass back to you. Are there areas within the CCDS that need to be updated in order to comply with the USCDI beyond the new data classes? In other words, are there additional standards updates beyond the addition of provenance clinical notes, pediatric vital signs, and the demographic pieces?
Sure, thank you. This is Avinash. Can you hear me first?
Yep.
Great. So I'll try to be quick and short, right, at least. So I'll just piggyback on what Mike mentioned, taking the example of problems. I think that's a data element that's in the common clinical data set, which is also in the USCDI. And the question, if I understand, is related to the terminology standards, the versions of terminology standards that are required to be the minimum standards that we established in the 2015 edition. As all of you that are part of the certification program know, that developers are allowed to update and move from the minimum standard that's there in the certification program. I think in the proposed rule, we had requested comments on whether, as part of the CURE's final rule, we should update the associated terminology standards and move up to the latest standard. There was a general support from commenters for updating these minimum code sets. Those are the SNOMED versions, the RX norm versions, and the like, LOINC versions that are, and there was a general support from commenters to update those code set requirements to the newest version as part of the final CURE's rules update of USCDI. So as we have finalized in the USCDI version 1, that's part of the requirements to be supported by various certification criteria. What you will see is that we have put forth the latest version, at least as part at the time of the final release, the latest versions of these minimum standard code sets that are now established as the new floor for the data elements that will be part of the USCDI. So hopefully that answers the question. It's again something that we know vendors are continually moving up, and we think that this update to the latest version really puts in the latest terminology standards to be kind of again part of the regular development cycle. But back to you.
Thank you, Avinash. I'm going to do, there's a couple on clinical notes, so I'm going to do those quickly, and then I have one on provenance, Avinash. I'm going to pass back to you in just a second. I'll do clinical notes really quickly first. There are several questions about clinical notes that have been not surprising on here because we've been hearing them elsewhere as well, in terms of what criteria must now include clinical notes. And then we have a question about whether those need to be converted to plain text if received in other formats. So if it's okay, I'm going to go ahead and just do both of those really quickly, and then Avinash, I'll pass to you for provenance questions. So clarifying that any update that has been from the CCDS to the USCDI, so any of the criteria that now include the USCDI, do include clinical notes. There are 8 types of notes that we finalized, and there is, this relates to the question about plain text, so I'm just going to go ahead and keep talking and cover that as well. So the clinical notes have a standard associated with the title of the note, right? So there's these 8 specific ones, and then they are essentially plain text machine readable notes. However, this is important to note that the intent of this policy is to prohibit certified health IT modules from converting clinical notes from a machine readable format to a non-machine readable format. For example, you cannot convert notes into PDF. However, clinical notes text that originates from outside the health IT module should be exchanged using its original format. So if you receive something and you were forced to store it as a PDF, then it would be okay to return it as a PDF. and we weren't aiming to imply that things needed to be converted in some fashion. So I know, Avinash, I was going to ask you about this one, but you have provenance coming up. So I will say that we will make sure that we can update program documentation about this. And then Avinash, can you touch on provenance a little bit? There is a question about the provenance author. And I don't want to actually get these questions wrong because I don't know this as well. So can you talk a little bit about provenance and what is in the FIRE R4 and US Core IG versus what we've done with US CDI?
Sure, we'll do that. So yeah, I think in the proposed rule, we had proposed 3 data elements as part of the provenance data class: the author name, author organization, and author timestamp. But as we finalized, we actually got feedback that author name may not be applicable all the time and may not be available. So I think from a US CDI perspective, we finalized with author organization and author timestamp. But if I understand the question, and it's a nuanced question, that what we did, especially for the API certification, as Beth you alluded, we do also require implementations to be compliant with both the FIRE Release 4 standard and more specifically the US FIRE Core implementation guide. And what we see is that, and again, I think in our criteria, in our final QoS rule, what we have clarified that as implementers begin implementing and complying with the US FIRE implementation guide, that all the data elements in the various FIRE resources that are required to be implemented, all the data elements that are indicated as mandatory and must support by the implementation guides, they will be required to be supported as part of the API certification criteria, at least as part of the requirements for the API certification. So in a way, what you see here is, and that kind of goes back to what my colleague Mike was mentioning, that from a data policy perspective, US CDI, the provenance has author organization and author timestamp as the minimum required, but specific implementations of the data policy. So in particular for the API certification, the use of US FIRE Core has additional requirements due to the way in which the implementation guides have defined those resources. And again, through our criteria for APIs, we require mandatory and must support data elements. So if author is a mandatory or must support data element in any of the resources that are required to be supported, then it will be required as part of certification. Thanks, Beth. Back to you.
Thank you, Avinash. So Mike, I'm going to switch to you. A couple of questions related to the EHI export criterion. There was one that I just went ahead and answered, that was, are we restricting any other uses of the criterion? The answer to that is no, we're not restricting any other uses of the criterion. The use cases that we mentioned are the ones that are in our regulation for certification. But can you describe what EHI is required to be included for certification to the criterion, and what there's a reference to stored by, and then what are the technical requirements for the criterion?
And the technical, so okay, what EHI it is, then you said what EHI it is, the technical requirements, and I think I missed the in
There's
between,
a
like explain what's stored, yeah, right.
Yeah, exactly.
Okay, I will try to do this justice, but give me 1 second here. I'm just trying to, obviously we published, and this was I'll answer a question that at least came to me, and it was actually, the answer to it was embedded in our footer, if you ever saw it on the, when we had the rule posted on our website, which is, you know, why the big difference in page changes between the display version now and the version you guys had on your website, which is about I guess it's 103 page difference. So that was pretty much all from removing the footer. when you have over that many pages. That's how much it all adds up to. And then we made some formatting changes based on discussions with the Office of Federal Register to conform with their requirements. Why I say all this to you is because I'm going to point you to, it's around page like 176. That's just kind of in the middle of the discussion about all of EHI export, but I really encourage you to look at that, particularly because you can find your answers that I'm going to give you there related to these questions. One key point, coming back to what EHI we're talking about, we're still using the same definition of the EHI that we use in information blocking. But what everybody should be aware of and understand is the EHI that you may have in your product that gets certified to this criterion doesn't necessarily equal all the EHI as an actor. If you're an actor under information blocking, a provider or developer of certified health IT, doesn't necessarily equal the EHI that you may have to provide for the purposes of information blocking. Once again, like when I talked to you earlier about how USCDI and certification program helps support interoperability and the ability to provide this data, this electronic information to other providers and to patients. It's the same here. This is a way we're hoping through the certification program to get EHI out of a system, and that helps support your compliance with information blocking if you're a covered actor. So it'll vary from product to product, what is the EHI in that product. And it's not just what module gets certified, to be clear, it's the product that the module is a part of. And what I'm talking about is what gets listed on the Certified Health IT Products list, product list. That's what we're talking about. The data that is stored in that or stored by it. So when we talk about stored, it's in it, the product itself, or that product stores it maybe in an ancillary system or data warehouse. So that's what would need to be exported. And when we talk about the export and the technical requirements, it's the EHI, but not in any standard format. There isn't a requirement for a standard to be standardized the data, so to speak, I guess is the way to say it. So it's still it's an export file, and then what is essentially like a data dictionary, the way to understand that export file. So the information has to be in a computable format. There has to be a publicly accessible hyperlink as well, and that needs to be updated. So clarity that was provided in the final rule regarding that is we expect that developers will keep that part updated so that data can be interpreted. Does that answer? I think that answers the question. It's still the two use cases. I can't remember if you mentioned the use cases, but it's the single patient and then the broad set of patients. So single patient export, and then like essentially patient population export for that provider. So all their patients. And again, that should help from information blocking perspective. And then even that single patient one is going to probably help in terms of, right of access under HIPAA and getting patients' information available to them in electronic format.
Thanks, Mike. And yeah,
I think that covers it. All right.
Yep, you did. And the use case
Okay.
was about whether there's a restriction, and there wouldn't be for any use beyond those is not restricted by our program.
Right,
so
they're just not covered, right?
Right. We are running short of time, and looking at the questions, I'm seeing a whole bunch that relate to communications. So Mike, I'm sorry to make you talk some more. If we can
oh boy. Okay.
talk a little bit about the communications condition of certification, I think that will be helpful.
Mm-hmm.
There are several questions that are in here.
Okay.
So if we can just start with maybe do a quick overview of it, and then I'll try and triage down to a couple more points to make sure you hit them.
Okay, I'll do my best real quick here. But I know when I was I participated in that COC conditions of certification presentation last time. I think I went over my time talking about this particular condition of certification maintenance requirement. So there's 6 subject areas that Congress laid out: usability, interoperability, security of health IT, user experiences, business practices related to Exchange, and manner in which the health IT is used. We provide definitions of what we mean by that, all those various topics. We also explain communications is interpreted broadly, so that includes verbal, written, and visual communications. And so that includes, as referenced earlier in Rob's presentation, screenshots as well as video. Then we broke it down into 2 separate types of communication. So the statute doesn't do that, but we did that via reg. And we talked about what's considered unqualified protections. And so that's where a developer can place no restrictions on any communication regarding those 6 subject areas that I just mentioned, but in particular circumstances. So that's when we laid these out, such as it's required by law that communication to happen regarding that one of those subject areas, and then certain other types of communications, like for example, if it was a safety matter, that could be without unencumbered by a provider conveying that concern about safety matters to government agencies, to PSOs, accreditation organizations. And then similarly, we talked about cybersecurity threats being unrestricted in terms of disclosures to government agencies. On the flip side, when we're talking more broader disclosure, like through social media, YouTube, what have you, we do permit developers to place certain restrictions, and those restrictions vary based on different factors. So in one instance, if it's an employer or contractor, a developer is allowed to place restrictions. If it's non-user facing, so the perfect example on that is if it's something like source code that leads to a cybersecurity threat, you can't just go and put that out on the internet. Now you could, if you're a communicator, give that to like I just mentioned, the federal agency, or conveying that without any restrictions. But developers can say you can't disclose that, out on YouTube. And then obviously the big one is on IP. So developers have a lot of, I don't say a lot, but they have an ability to restrict communications to protect their disclosure of their intellectual property. And there's, we're up at time, but essentially it's like no broader than necessary to protect their interest, and it also has to be considered consistent with the other permitted restrictions, and that's in particular we have a section on screenshots and videos. And then the one thing that besides that is they can't preclude a public display of a work subject to copyright protection if it would reasonably constitute a fair use of that work. So that was a 3-minute run through on the whole communication one.
Yeah.
Is there a particular question, that maybe I can answer? I know we're at time.
So you covered several of them. And then the last thing to cover is just how soon does the communications condition of certification apply? In other words, how soon would a healthcare provider be able to not have restricted communications about a product?
So that reminded me, actually, you saying that there's 2 parts of that, right? So there's your condition and your maintenance requirement. And the maintenance requirement is actually addressed in our fact sheet that we put out on enforcement discretion. So 60 days from May 1st, the rule will be effective, and this condition of certification will be effective as well, and compliance would be required starting at that time. Granted, there's again the 3-month enforcement discretion. So if they weren't necessarily in compliance right away after that effective date, they have some time to get into compliance where we wouldn't enforce. There's the maintenance requirement that says, look, if you have any contracts or agreements that contravene the condition of certification I just described to you, you're to provide notice to all your customers that is unenforceable, those provisions, until you eventually update those agreements to take such provisions out or modify them. we said you had to do that once this year, this calendar year, and then annually thereafter until you changed your contracts and agreements. What we're doing through the enforcement discretion would permit a developer to send that notice up to 3 months after the end of the year if they couldn't, get it out because they're helping support their customers address the COVID-19 emergency. So they could then maybe not get that notice out for to comply with the 2020 requirement until all the way to, I guess, end of March of 2021, and that's noted on the fact sheet. I think that covers that part, the compliance part of that.
Yes, thank you, Mike. And we've actually gone a little bit over, so I will thank everyone for joining us and for sticking around for a few minutes extra. Again, we will be taking all of the questions that we got in writing and didn't get to yet to help inform the educational materials that we make, the resources that we put on our website, and our next, the questions that we get sort of present to in our next round of webinars. We do have more deep dive upcoming webinars on APIs coming up next, and I can't see the schedule, sorry, it just got hidden under my webinar notice. But please take a look at that and look at our website. There are resources on there. Again, we will be taking these questions to inform the development of continuing resources and educational resources to help everyone understand how this will work now that it's been finalized. Thank you all for joining us.